Good afternoon. It's now 4 o'clock. I'm handing over to Dr. Mkube. Dr. Mkube, over to you.
Yes, thank you, Renier, and good afternoon to you, colleagues. Welcome to our webinar conference. The Summer CEO is here, and we'll be happy to have him give us a word to open the conference. Thank you. Over to you, CEO.
Muted. Okay. No, thank you very much, colleagues, and thank you to you, Hlengi. Let me take this opportunity to welcome everyone who is here. We are really ready to deliver on the promise of grappling with the ethics as we move on into this year. We've seen exciting things coming out of the HPCSA with ethics that relate to AI in healthcare. So I take this opportunity to welcome everyone, and we're looking forward to exciting discussions. Thank you very much, Mkhengi.
Thank you. Thank you so much, CEO. We will start with our first presentation, which comes from Dr. Venter. Dr. Venter is an esteemed clinician. So she's not just an oncologist, by the way. She's also a palliative medicine specialist. So she's a firm believer that medicine is as much about listening as it is about treating. So after a decade in oncology, she mastered, where she had mastered the art of targeting tumors, she now devotes a clinical expertise in palliative medicine, proving that sometimes the most powerful intervention is not a scalpel, ladies and gentlemen, but a conversation. Her academic journey is nothing short of rigorous. She holds an MPCHB, an MMed, and a postgraduate diploma in palliative medicine from the University of Cape Town. After that, she took her skills global and did an advanced training at Harvard Medical School, because apparently 3 qualifications are not always enough. She's the driving force behind the palliative care network in Stellenbosch, where she serves as both a board member and a clinical, and she serves as both a board member and a clinical volunteer at Stellenbosch Hospice, where she continues to blend expertise with compassion. She's the co-founder and clinical lead of the Association of Palliative Care Practitioners in South Africa, and has helped grow the organization from a bold idea in 2018 to a thriving network of nearly 300 professionals spanning medicine, nursing, social work, and allied healthcare. Her special interests lie in serious illness communication, because let's face it, navigating conversations can be a little bit harder than medical school itself. She's passionate about expanding access to palliative care. She champions systematic healthcare challenges and provider support to ensure that more patients receive person-centered care that they deserve. When she's not improving palliative care across South Africa, she can likely be found advocating for the power of a well-placed joke in a clinical setting, because in her view, a little humor never hurt anyone. Dr. Mike Venter, to you, ladies and gentlemen. Thank you.
Thank you very much for that introduction. I'm very grateful. It sounds that's definitely more than I shared with you. So thank you for this opportunity. And I'm particularly grateful that I'm first on this program. Usually palliative care and end-of-life care gets the graveyard shift at conferences and events such as these. So I'm particularly grateful for that. And I'm going to share my slides. Just wanting to make sure that it's all right.
100%. Thank you, Dr. Venter.
So I took the liberty of interpreting the title a little freely, and I'm wanting to make this a little bit of a marketing and branding exercise for end-of-life care and palliative care. We definitely have a branding problem. And with a call to action that all healthcare providers should make palliative care its business. It's our ethical imperative as healthcare providers to make the palliative care approach part of our own clinical practice, to integrate it into our healthcare services and in our healthcare systems. We all work with patients who are sometimes at the end of life, sometimes on the knife's edge. You know, one planned for one thing, and with this intervention, things turned out differently. So we all get to do with patients who are seriously ill, either on a daily basis or definitely from time to time. I think probably this starts with some thinking around our own mortality. What are our own fears around our health going forward? What are our wishes for our own healthcare provision going forward should we become seriously ill? And I think there is some research that shows doctors typically don't advise treatments for themselves that they would for their patients. So there's a lot of confusion out there about palliative care and end-of-life care. What is it? What isn't it? And here is a jumble of pictures, and I'm wondering if you could perhaps classify them into different quadrants. What do you think we do? What do you think the media thinks we do? What do you think we do? And if I were to split them up, I think we would want to believe that we are functioning on the left side, the yellow happy side, where we are engaging with patients timeously, talking about their illness, their wishes, their fears, and really focusing on quality of life. We are not death's angels. We are not Florence Nightingales or angels or butterflies. And in the media, if you Google palliative care, the only image that ever comes up is this one of dying hands. But palliative care is about a lot more than that. It's about the relief of symptoms and stress of serious illness. And we like to believe that we are experts at that. We have to acknowledge that the patient is more than just their illness, and they have biopsychosocial and spiritual dimensions and needs. A patient is usually not an island. There are a group of people around them, whether family or loved ones or significant others. And this is the type of care that we really need to offer within a multidisciplinary team. And we do this preferably alongside the patient's usual healthcare providers. The typical team will have a doctor, nurse, social worker, spiritual carer, and then from time to time, others like dietitians or physiotherapists can really add their insights to improving a patient's quality of life. Previously, in the old regime, there was very much this line of thinking in that one focused solely on the illness. You tried whatever you needed to do to manage the illness. And then at some point in time, there was a watershed moment and the patient would be transitioned to hospice or end-of-life care. In the last, I think, 15 to 20 years internationally, the thinking has changed in that palliative care needs to be introduced from the time of diagnosis. And this is also in line then with the WHO definition of palliative care. And initially, the touch might be light. It might be a conversation about advanced care planning. It might be managing one or two symptoms. But then as the disease progresses, the input of palliative care will become more significant. And then really just towards the very end is the hospice end-of-life care. And when patients are referred so very late, the impact that we can have on quality of life, on decision-making is really minimal. So we need to get involved early on. The types of competencies that we might and tasks that we might fulfill are various and really depends on the clinical scenario, but also on the patient and family's needs. Often pain and symptom management is key. These patients can have complex problems, bowel obstruction, neuropathic type pains because of tumor invasions, and we need to pull out all the stops to get pain and other symptoms controlled. One of the things I really like grappling with is around complex decision-making. What is a patient's goal of care? Just today, I saw an elderly gentleman well into his 90s in ICU with sepsis, hemorrhagic cystitis and severe renal failure, what to do. He's on inotropes. Do we start dialysis? Don't we? And so a simple conversation with the family about what is his goal of care? What have things been looking like for him in the last while? What would his wishes be? What is the most likely outcome for us? And then determining what the approach should be going forward. In this particular gentleman's case, it was that we need to focus on comfort. And so whatever intervention we were going to give him going forward would be in line with that goal. Sometimes difficult decisions around withdrawing or withholding of care, elderly dementia patients, patients with MND, do we put PEG tubes in or not? What is the evidence? Is this in line with their goals and wishes? When do we think there's non-beneficial care, and helping colleagues think through the ethical decision-making process and getting to a place where everyone is comfortable with the decision, but also where the family and the patient are on board, understanding, and in agreement with the recommendations. For this, excellent communication skills are paramount. Often not really what we say, but how we say it. And when you go into that loop of sharing more and more information and it doesn't seem to sink in, probably something around the style of your communication is lacking. And if you were able to adjust that and improve your communication skills, you'll often find that things fall into place a lot more simply. And for me, it's been quite eye-opening in that my own moral distress with some of these conversations has eased, because I feel more confident in the way that I communicate. Care coordination I found to be very important. We all work in silos, every discipline focusing on their own organ, and we need one person to have an holistic view of a patient's care and whatever is true and important around them, and so to come to a better coordinated care situation for a patient. And for this, we need a team. So palliative care has systematically shown that it improves the patient and family's serious illness experience, it improves the quality of serious illness care, and it improves the use of healthcare resources. A paper that was published in 2015 already, and I don't think that has changed much. It shows that healthcare costs in the last year of life are 3 times higher than in the second last year of life, and that the spending is 12 times as much as those on those in the last year of their lives than they do on survivors. And this doesn't always make sense, as it doesn't equate with quality nor really with life expectancy. If you look at the new Global Atlas on Palliative Care, I've lost what the WHPCA stands for, but South Africa is not too bad in terms of its palliative care service delivery. This is the estimated number of patients receiving palliative care, and it's usually linked to the use of opioid use. We're not doing too badly, but compared to some of our northern countries, definitely a lot still needs to be done. When looking at the public health model for palliative care, there are 4 elements that need to be considered: policy, drug availability, education, and implementation. In 1990, the World Health Organization declared palliative care as a health priority. And in 2014, the World Health Assembly acknowledged that palliative care is an ethical responsibility of health systems, and that it is the ethical duty of healthcare professionals to alleviate pain and suffering. And our government was a signatory to that document. And following that, we developed a national policy framework and strategy on palliative care, which was launched in 2017, but lapsed in 2022 without really much happening. And since then, I don't think we can only blame COVID. There's been really no movement in reinvigorating or actioning that policy. We are not 100% sure that palliative care is part of the NHI conversation, although realistically, we are doing NHI in the community all the time. Most hospices serve patients from either side of the payment gateway, the both state patients and scheme sponsored, for lack of a better word, patients. And so we definitely need to be sure that we are also on the NHI agenda. Palliative care is also very definitely part of the health, universal health coverage, and really there's no reason why we should be so misrepresented and underrepresented within the healthcare system. We, as I mentioned, are doing reasonably well with regards to drug availability, but we have found that often we have oral morphine available on shelves in pharmacies, but doctors are not that clear on how to properly prescribe oral morphine or how to manage the side effects of morphine. Pharmacists need to be able to know how to mix morphine, and then patients need to be able to get to the clinic to get their morphine supply. A big sore point for us is that nurses are not trained to and allowed legally to be able to prescribe morphine. And I think in terms of access, especially in rural areas, nurse prescribing would go a huge way in relieving significant pain and suffering. We all know that few of us had any palliative care training at undergraduate level. Slowly, this is now changing, but really very slowly. In nurses and social worker curriculums, there is no palliative care. At UCT, in a recently published paper, UCT was the only university to meet the 40-hour recommended training for undergraduates. And there's very little contact time with the other three universities who do offer this as part of their undergrad curriculum. Really a short, small little week that most students, you know, they go off and drink coffee instead, not really understanding or realizing the importance of this topic and field of expertise. In our postgraduate training at the moment in South Africa, oncology does offer 60 hours as part of their MED, and they are also marked on it, but there's no other specialty at this time that includes any palliative care training within their specialty. And we are awaiting specialist level approval, and that should happen within the next, I don't know, we've been saying in the next year, we've been saying that for quite a while. In terms of implementation in South Africa, in the state sector within hospitals, there are a very few, you can count them on one hand, services that are up and running. Quite a few of them are there thanks to grant funding, and we all know what happens to grant funding. In the private sector, there's really no incentive for palliative care services. People are serviced and receive health care without any real measurements of outcomes. And in the home-based care setting, there are a few medical schemes who now have acknowledged the benefit also to their pockets of palliative care at home. These are services are offered by some palliative care, dedicated palliative care teams and hospice member centers. What is the APCC? Used to be the APCA of South Africa. And in the state sector, these NGOs need to offer this service really dependent on donor funding and fundraising and cake sales, which is really not something that we do for appendectomies and cesarean sections. So the second part of my branding exercise is really to introduce you to the Association of Palliative Care Practitioners. I think this organization can be a good partner for those of you who are interested in really getting involved or at least exploring options around palliative care. As mentioned, we got established in 2018, and our membership is growing slowly but steadily. Many people have done the additional palliative care training, and others are really just interested in the field and are wanting to learn more and integrate it into their own daily practice. PALPRAC offers a community of practice where we are able to offer peer support and mentorship. Sometimes working on your own can be quite daunting, and it's great to have a team of like-minded professionals who are able and willing to support. We try and develop relevant patient resources. We have, for example, a whole lot of resources on the use of oral morphine that we have translated into our various languages, explaining to people about nutrition and hydration. You can have a look on our website. There are lots of resources that can be printed out. Also to providers, resources around advanced care planning, the SPICT tool, how to identify patients with palliative care needs. There is a lot of information that you will find on the website. We also do a lot of Zooming with various stakeholders in the industry, whether it be the Department of Health, our other palliative care partners, medical schemes. So a lot of advocacy and engagement with the various system stakeholders to try and strengthen palliative care service and access. There are many CME or training opportunities. We offer a monthly PalliChat CME, which is on a diverse range of topics. This last week, we had one on renal palliative care. On the EM guidance, I think well known to many of you, their new academy, we are busy creating and developing short training modules. The first was launched a month ago on prescribing of oral morphine. And then there are the other more traditional avenues, the postgraduate diploma, the certificate course in palliative nursing, and then there are various short courses that are run online. So really lots of opportunity to learn and upskill in palliative care. So what can you do? For one, upskilling, as I mentioned. If you're in a leadership position, my question would be to you is whether you have any good quality palliative care available in your service, your institution, or your geographical area. And if not, how can you strengthen that? Could you send your staff on a short training course, maybe more than one, so that there's a team who can then train the rest of the people in their institution? Are you including palliative care in your policy and in your budgets? Budget is always a big thing. And although palliative care isn't expensive, it isn't cheap either, but it's a high value intervention in that it really does improve quality and save or a better use of healthcare resources and a reduction in cost. Do you perhaps have a role to play in advocacy with schemes or the DOH, or maybe mention us at the NHI conversations? And then I think importantly, never to say there's nothing more we can do for you. There is always something we can do for our patients. There's always a symptom to manage, a family member to support, but nothing is never part of our vocabulary. And if you're not feeling comfortable or able to offer what is required, some patients are definitely more complex, others basic knowledge of palliative care will suffice. But if not, and you're able, please refer these patients timeously. And then lastly, I really am using this as a marketing tool. We have a conference in June in Durban. The first conference in 2023 was really well attended and rich in terms of content. And we would really like to invite you all to attend this conference and help build on the network. So to finally finish off, I really would like to encourage you to understand that palliative care is everyone's business and engage with you, support you to please make this part of your everyday practice. Thank you.
Thank you so much, Dr. Venter. It's and I'm seeing a lot of hands being clapped and lots of compliments for the beautiful presentation. The most unique thing about your presentation is that there's no questions. Yes, there's no questions, and I suppose it means it was very clearly delivered, beautifully delivered, and very informative. It also probably is an indication that we should be hearing more from you, so that people get to know and understand more, and be able to engage you a lot more. And so thank you so much. We really appreciate the insights that you gave us, and I'm sure a lot of our colleagues will be considering careers in palliative care, and also, better aware of how to refer patients to palliative care early. Yeah, thank you so much.
Just the last comment, in ICU today, when I was seeing this patient with the renal failure, and we stopped on the script, stop this, stop that, stop that, the nurse in ICU said to me, "So you studied for 7 years just to be able to say stop, stop." So anyway.
Thank you so much. We will move on to, still on palliative care or end-of-life issues, to Reginald Masimula. Reginald Masimula is an admitted attorney and the medical legal advisor at SAMA. So his legal career is shaped by deep commitment to justice, advocacy, and the intersection of law and healthcare. He's a proud alumnus of the University of Pretoria and embarked on his legal journey at Mark Roberts Attorneys in Pretoria, where he gained exposure to diverse fields of law, laying the foundation for his expertise. He later joined Van Brenda and Herbst Incorporated, where he was the youngest litigation attorney in the department, and quickly distinguished himself through his tenacity and legal acumen. His career took a definitive turn towards medical legal practice when he joined the Medical Protection Society, MPS, South Africa Services as a case manager, where he managed and handled complex medical and dental cases for South African practitioners. This role provided him with invaluable insight into the legal challenges faced by healthcare professionals, solidifying his passion for the healthcare sector. It was this experience that led him to his current role as medical legal advisor at the South African Medical Association, where he continues to advocate for and support medical professionals in navigating the intricate intersection of medicine and the law. Beyond the courtroom and consultation rooms, Masimula is deeply involved as part of the senior leadership of the Catholic Church in Pretoria. His dedication to community service extends beyond faith-based initiatives, where he has spearheaded numerous outreach and development programs aimed at uplifting disadvantaged communities. A passionate educator at heart, he is actively engaged in mentorship and training activities with ambitions that contribute to academia in the fields of law and healthcare ethics. He's very dynamic, multifaceted, and deeply committed to both the legal and healthcare sectors. He's driven by a vision of empowerment. And one thing he firmly believes in is that the law, much like medicine, is most powerful when used to heal, protect, and uplift those who need it most. Colleagues, I present to you Reginald P. Masimula. Thank you.
Good afternoon, everybody. I hope everybody's doing well. And my apologies for not being able to switch on my camera. I just seem to have a technical glitch, but do bear with me for that. And yes, thank you so much, Mthengi, for the introduction. Just wanted to check with you, Mthengi, my slides are visible, correct?
Yes, visible.
Thank you so much appreciated. Yeah, so I've been asked to take you through a course, or rather, we can call it a course of some sort, on the legal and ethical considerations to end-of-life care, as we so touch it as palliative care. And we're basically going to look at some of the considerations that practitioners need to take into account when dealing with this. Many a times, many of us find ourselves in this conundrum of not knowing what to do, how to deal with what situation, and so forth. And this is basically a crash course to basically give you some guidelines in terms of what the legal position is, what considerations to take into account in that instance, and also just to be able to guide you as you navigate these complexities. So let us get into it. So we're going to look at some ethical principles. So there are 4 ethical principles that we are primarily going to be looking at. But before we get into that, let us start off with the definition of what end of life is. End of life was defined as the healthcare that is provided at the time leading up to a person's death. End of life can also be provided during the hours, days, months, just before somebody dies, and basically comprises, as the previous speaker mentioned, Doctor, that these are the emotional needs, this is the physical comfort, the spiritual needs, as well as the practical tasks that are needed or taken into consideration during this time. Through definition, when we're looking at how the guidelines, particularly from the HPCSA, define palliative care, is that it provides those living with and dying from any advanced, progressive, and incurable conditions, regardless of age and or settings. Palliative care is provided throughout the journey from diagnosis to the end of life. And as the patient's disease progresses, there is a need for palliative care will increase. However, we will then see that the level for curative treatment will, in that particular instance, decrease. So that is now, so that we just have a holistic understanding of what is end-of-life care, what are we looking at? Because remember, this allows us to be able to identify situations as to whether some of these principles will be applicable or not. So what we have is that we have what we define as advanced healthcare directives. So advanced healthcare directives can come either in 2 forms. Either you'll have one as a living will, or it will come as a form of a power of attorney. So basically, this is a legal document in which a person specifies what actions need to be taken for their health if they are no longer able to make decisions for themselves because of illness or incapacity. So one thing to take into account here particularly is that this particular piece of document basically shares the wishes that you would have at this particular stance if you were well, when you've got full capacity to make these decisions. When we're looking at the definition of capacity, maybe perhaps it's just to park here, is that we're looking at one's ability to be able to comprehend the decisions in which they are making. Legal capacity, this is the right to make decisions and to form legal relationships. So you're forming a legal relationship that is binding upon you. During your time of end of life, you might find that that capacity might be diminished, either due to whatever illness that you are facing, and certain decisions need to be made. So now this capacity that you have now been able to exercise prehand is then able to then take effect at this particular stage. So as mentioned, that living wills, according to the National Health Act, health services may not be provided to a patient without informed consent. Informed consent has been such a huge issue in the field currently, where practitioners are just all up in arms on this. When does consent come in? When does consent stop? Because we are now also finding ourselves with patients and practitioners before the HPCSA responding to complaints because there either might have been a lack of consent somewhere in the process. So from this living will, this is basically where we would get that consent element brought through. It is implied that if a patient has a living will that declines healthcare, it must be taken into account and treatment should not be provided without the patient's informed consent. Any decisions about withholding or withdrawing treatment should take into consideration the values of the patient and the families, as well as any ethical guidelines from the HPCSA, which we will have a look at later on in this presentation. These guidelines make it very clear that discrimination based on age, disability, race, color, culture, belief, sexual orientation, gender, lifestyle, social or economic status, or other irrational grounds will not be tolerated. Looking from a constitutional perspective, this is where we see the application of Section 9 of the Constitution, the right not to be unfairly discriminated against. So we are now seeing ourselves in this instance where there is this interplay, this conundrum that some of our practitioners faced as to their own beliefs or their own viewpoints about what needs to happen in that particular situation versus that of the patient. So now we are now seeing this particular position saying that a patient's position is the one that needs to be taken into account. And as a healthcare practitioner, um, this may this may be compromised. Just my apologies for that. Just checking in, Klengi, can you hear me?
Yes, we can, loud and clear.
Has my sharing stopped for some instance? It seems to have on my screen.
I can see your slides.
Oh, can you see my slides? Okay. Okay, I can't see mine. Just my apologies. I'm just going to stop sharing for like 2 seconds, just to jump on. I'm not sure exactly what happened there.
Our colleagues, sorry about that. We will wait for Reginald to come back. In the meantime,
I think I'm back again. Thank you so much. My apologies for that. So let us now look at the ethical principles that are taken into account when dealing with end-of-life care. So when dealing with end-of-life care, there are 4 principles that we take that we will just have a look at. One is we're going to look at autonomy, we're going to look at beneficence, we're going to look at the non-maleficence, as well as we're going to look at the ethical principle of justice. So let's get into it. What is the first one? The first one, it is autonomy. So when looking at autonomy, we are going to be dealing with the consideration of a patient's right to self-determination. Self-determination in this instance would refer to a person's ability to make choices and to manage their own life. Being self-determined means that you feel a greater control as opposed to being non-self-determined, in which, in that particular instance, it almost feels as though control has been passed on or given over to somebody else over your own life. It is in this instance to take into account that we're looking at Section 27, which grants everybody the right to choose and to make decisions about their own healthcare. Everybody has the right to decide what kind of care that they should receive and to have those decisions respected. This principle emphasizes physicians' protection of their patients' rights to self-determination, even for patients who have lost the ability to make decisions touching into that capacity element. At the end of life, the priority of making decision belongs to the patient. If the patient has lost that ability to make that decision, those decisions are made according to the patient's directives, for example, that we might have either in a will or in a power of attorney that we just touched on earlier. The second principle is the principle of beneficence. So basically, this is an ethical principle that refers to the moral obligation to act in a way that benefits others, meaning that it's promoting their well-being and legitimate interest. Beneficence in this instance is defined as an act of charity, mercy, kindness, with a strong connotation of doing good. As practitioners, we might have touched on this while we're looking at medical ethics, because this is something that is very strongly entrenched in that. Beneficence is a consideration of it is a consideration of doing good. It basically looks at you as a practitioner and says you have a responsibility, or rather a calling to a higher standard of professionalism, which is basically morally imperative. This is one that advocates for a higher standard and strives for greater good. So as practitioners, we are now put into this situation whereby there's a moral duty upon us to act good, meaning that in these end-of-life situations, at some point, the decision making that we take needs to promote acts of goodness. Let's look at the third one. This is non-maleficence. So this principle refers to the causing of unnecessary harm. I'd like to just bring emphasis on the word unnecessary. Although some medical interventions might cause pain or some harm, maleficence refers to the moral justification behind why harm is caused. So this is basically going to put on the justice scale, should harm then be caused, does the outcome of the harm outweigh the harm that the patient is going to to feel. So harm can be justified if the benefit of the medical intervention is greater than the harm that the patient and the intervention is not intended to harm the patient, but rather could be as an adverse consequence thereto. The final principle that we're going to look at is the principle of justice. So basically, this ethical principle of justice is about ensuring the fair distribution of health resources and requires impartiality in the delivery of health services. Healthcare providers have the ethical obligation to advocate for fair and appropriate treatment of patients at end of life. This can be achieved through good education and knowledge of improved treatment outcomes. You know, from this on, looking at education and knowledge of good treatment outcomes, this is perhaps how we see this obligation on us as healthcare practitioners to ensure that our CPDs are up to date, you know, just so that once we find ourselves in some of these situations, that we are able to provide our patients with the most updated, most relevant, and best outcomes for them in those particular situations. So where do we find this dilemma, end of life, or when these ethical principles come into play? This can be seen when we're dealing with cardiopulmonary resuscitation. This is CPR. This is also seen when we're dealing with mechanical ventilation, extracorporeal membrane oxygenation, and mechanical circulatory support, you know, dealing with terminal sedation, withdrawing or withholding of treatment, euthanasia, which is something that is very, you know, very dicey, that many of us hopefully at some point will get confronted with, but hopefully not. But in case you do, hopefully this will just be able to give you some guiding principles as to how to maneuver that, as well as a physician-assisted suicide. So this is where instances where we can find this dilemma. So let us look at CPR basically. So what factors can one take into consideration as to when to administer CPR? This is basically looking at a patient's preferences, the estimated success rate, the risk of the procedure, as well as the perceived benefits. These are the factors that we will take into account. A competent patient may elect not to undergo CPR in the event of a cardiopulmonary arrest. This is then we will find this document called a DNR, do not resuscitate. The HPCSA guidelines will refer to this as a do not attempt resuscitation order. So this is basically a document that gives or shares those wishes that should I find myself in a situation where there's a cardiopulmonary arrest, do not attempt to resuscitate. Despite this request, a patient's family members may ask a physician to perform CPR. We do see this from time to time because a patient might want a particular outcome, but his or her loved ones might feel that that decision that they took might not have been the right one. And now as a healthcare provider, you are now almost kind of stuck in between. You know, you are dealing with the DNR on one end, you've got the patients on the patient's family on the one end saying, perform CPR. What do you do in those instances? If a patient is conscious and has the ability to make decisions, the patient's decisions are then taken into account. That's something to also consider. That should you find yourself in that interplay and you are able to communicate with this, when the likelihood of that happening is almost kind of very slim, because if a patient is suffering a cardiopulmonary arrest, I don't think there'll really be time to actually engage with them as to do we still proceed to perform the CPR or not. But in those particular instances, I think this is just an important principle to take into account. So when DNR orders may be lawfully used, so this is where my apologies. This is where a patient has made an advance directive, the living will or power of attorney, and has made an informed decision to refuse CPR. When clinical judgment concludes that CPR is futile because it would not restart the patient's heart, breathing, and restore circulation. This is where a patient is dying from some other irreversible condition. This is where we will see this DNR coming through. Or when, after discussions with the patient and or his or her family, an agreement is reached that the benefit of CPR are outweighed by the burden and risks involved. For example, this is where there is a high risk of substantial brain damage. So then after that conversation, then the decision then would be to not perform CPR. So this is the three instances in which we actually see the application of DNRs. So now let us look at booklet 17. Booklet 17, these are the ethical guidelines on palliative care that basically tells us what considerations do we take into account. Particularly in this instance, we've paid a particular focus on some of the ethical duties and guidelines that are provided by the HPCSA to take into consideration. It basically says that health practitioners providing palliative care intervention unless it is shown that they clearly cannot understand the information that is given to them. It is for this instance that patients and not the healthcare provider providing palliative care to determine what is in the best interest of the patient. Health practitioners providing palliative care must understand and respect that patients' decision making may be guided by values, customs, and beliefs which are different from that of the particular practitioner. If a mentally and legally competent patient who is fully informed of the benefits and risks of treatment consents to or refuses a particular course of treatment, their decision must be respected, even if the health practitioner providing the care believes it will result in serious harm or death. These are the guidelines that puts that must element. So it does not provide a discretionary element, but says that patients' decisions need to be taken into account. When respecting patient autonomy, however, does not mean that the patients are entitled to illegal, unethical, or medically inappropriate treatment simply because they have requested it. Remember, when we're looking at that, at some of those ethical principles, it is our responsibility to uphold a higher moral standard. That yes, and as much as patients have rights to their own body, patients have rights to healthcare, to healthcare. But as a practitioner, it is your responsibility to also ensure that you do not find yourself administering illegal, unethical, or medically inappropriate treatment just simply because a patient asked you to do so. This will, in most instances, expose you to a lot of risk. Should a patient request illegal, unethical, or medically inappropriate treatment, the health practitioner providing palliative care should reassure them and their family of the sound treatment options available to the patient, subject to consent by the latter or his or her next of kin. So it is very important that when we find ourselves in those particular conundrums, whereas a patient has one particular wish, which perhaps in this instance would be unethical, illegal, or medically inappropriate, that we find ourselves and engage in those communication with the patient. This is, for example, that will touch on our previous CPD event that touched on medical records. That these discussions will be contained in those medical records. It's very important that you do have those discussions recorded. Record that you had discussions with the family. Record that you had discussions with the patient, and that these were the treatments that you the options that you communicated with them. And from those discussions, this was the outcome. This many a times allows us to be able to defend practitioners when we're sitting with either a complaint or some lawsuit of some sort. Because remember, what happens at times is that at the end of life, a lot of family members feel very aggrieved. There's feelings of anger, there's feelings of misunderstanding. They don't understand what is going on. And you could find that the family many times come after the practitioner, saying that what happened? What authority did you have in order to administer particular treatment? And these patient records are able to then assist us in those instances. So let us look at some cases. So there are two cases that we're just going to deal with for this particular discussion that deal with this issue, end-of-life care. The first one is a 1988 case. This is a more older authority in this instance. So basically, this is Clark versus Hurst. So in this case, the applicant's husband suffered from a cardiac arrest in the year 1988, leaving him in a permanent and irreversible vegetative state. He was then kept alive through a nasogastric feeding tube. The applicant sought to be appointed as the curatrix persona, giving her the legal authority to discontinue artificial feeding, despite it potentially hastening his death. So basically, this is where the wife was saying, listen here, I want to be appointed as the curator persona so that I can have the legal capacity and authority in order to make that decision. Because at this particular time, before you're granted that order by the court, the patient's wishes still are to be taken into account. So the patient, who was a medical doctor, was a life member of the South African Voluntary Euthanasia Society and had signed a living will stating that if there was no reasonable expectation of recovery, he should not be kept alive by artificial means. So now we're seeing a patient's wishes now on one end, but at the very same end, we're seeing a practitioner's efforts to try and keep this patient alive. In this instance, would be then through the nasogastric feeding tube. So we've got this interplay of these conflicting positions. So now, basically, in this instance, the Attorney General opposed the application, arguing that allowing the withdrawal of artificial feeding could be seen as euthanasia and that the court should not preemptively declare such an act as lawful. However, the court ruled that it had the discretion to declare the legality of the applicant's action, and the court considered whether discontinuing artificial feeding would be wrongful, assessing the quality of the patient's remaining life based on society's moral and legal standards. This is where we find Bonus Morris. It found that the patient had permanently lost brain functioning, um, to the extent that his life no longer met the legal definition of human life as commonly understood. So basically, at the end of this court case, the court ruled that the applicant could act reasonably in discontinuing artificial feeding. The decision would not be wrongful even if it hastened death. The curator persona must act in the patient's best interest, which does not always mean preserving life at all cost. The patient's prior expressed wishes should be honored. This is where we've got that autonomy principle honored here. And that the application was granted, and the court concluded that discontinuing artificial feeding would not legally be the cause of death. So that is the older authority that we find. But then we have a more recent case. This was now reported in 2017. This is the Minister of Justice and Correctional Services and others versus the estate of the late Strachan Ford. So in this instance, the case involved Mr. Strachan Ford, a terminally ill cancer patient who sought an order allowing a doctor to assist in ending his life without facing legal or professional consequences. So now the question that was before the court, or one of the questions that they needed to answer, is that could a medical practitioner administer a lethal agent at his or patient's request, or provide him with a lethal agent that he could administer himself. The High Court granted this order, but it was later revealed that Mr. Strachan had passed away 2 hours before the ruling had come through. So as a consequence thereto, this matter was then taken to the Supreme Court of Appeal, and the appeal against this order was upheld for 3 reasons. Firstly, the cause of action seized upon Mr. Strachan's death, making the order invalid. There was no thorough examination into the legal framework regarding assisted dying, and the order was based on incomplete facts and failed to follow proper legal procedures. Those were the 3 reasons they had used to set the ruling aside. The Supreme Court did leave the door open for similar future applications to the court, as it was also concluded that assisted suicide is not unlawful in all circumstances. Any future applications will have to be considered on individual facts within the context of the Constitution of the Republic of South Africa, which protects the right to life and human dignity. Consequently, the High Court order was then set aside. So what do we gather and learn from this? We gather that in these instances, it's a case-by-case basis. You need to find ourselves with a lot of conflicting positions and viewpoints that practitioners need to uphold. You're finding that you've got ethical duties and moral duties upon you as a practitioner to ensure that you basically act in your patient's best interest, to ensure that you uphold a higher standard, to ensure in ensuring that your patients get the best outcome. But at the very same time, this conundrum is played against the patient's right, that autonomy principle that comes through, where patients have the right to decide what to do with their lives, to decide what decisions need to be made in moments when they themselves are unable to make decisions. So it should also be noted that in situations where we do not find ourselves with any of these directives, for example, there is no DNR order or there is no living will, what in this instance the the position that we will follow is that we will follow the next of kin line. So we will check and consult with the family members of the patient, where we will discuss the options available. We will discuss the consequences of the position that we find ourselves in, and then and allow ourselves in a situation where the next of kin will then make those decisions. It is, however, very important that practitioners take into account that the court may be approached if you are of the view that certain decisions are not done in the patient's best interest. For example, if you might perhaps, if this is a long-standing patient of yours, and you know, for example, that he or she was estranged with their spouse, and now following this next of kin approach, you find yourself now the spouse coming through to make certain decisions. You might be of the view that the spouse is slightly compromised, and that the spouse might not necessarily be acting in the best interest, maybe perhaps due to some historical information that you might be privileged to. In that instance, as a practitioner, you've got the right to approach the court in order to put your position through, because in that instance, you'll be seen to have been acting in the patient's best interest. And ladies and gentlemen, that brings me to the end of my slide, dealing with the ethical as well as the legal considerations with end-of-life care. I really do hope that this was able to provide you guys with some good understanding and just some few considerations to take into account should you find yourself in this position. If not just you, but some of your family members as well. I hope this discussion sparks certain thinking processes within yourselves as well. Ask yourself those questions as to what do you want to happen when it's your turn in that particular position, and not just as a healthcare provider, but also as a patient. Mhlengi, that brings me to the end of my presentation. Thank you so much, my brother.
Oh, thank you so much, Reggie. That was brilliant. You can see there's lots of hearts, clapping of hands, thumbs up, to say well done. This was really brilliant. There is 2 questions for you.
Sure.
One of the questions is about an 8-year-old gentleman with gangrene who chooses not to go to hospital for care, and his family is very capable of escalating care. So how does the family go about that, and how does most importantly the doctor go about that?
Well, in that instance, if you're saying that the patient is, if I understood you correctly, you said that the patient is refusing care, correct? But the family is of the view that care should be provided in that instance. Well, obviously, you will have to look at the issue of capacity. Does the patient have the capacity to make those decisions themselves? If the patient is of sound mind, if the patient is old enough, then that will be considered. But at the very same time, there might be other factors known to the family as to why they want to provide that care. We do understand that, having a loved one, you try to preserve them for as long as you can. And maybe perhaps that is their position and what they're trying to achieve. In that particular instance, they've got every right to approach the court and make an order whereby, of course, the court will follow the position of law. Firstly, respecting the right to autonomy. If the patient is of sound mind and has the right capacity to make those decisions, and secondly, they will consider the family's position as to why are they bringing this application. As mentioned and seen by these 2 cases that we looked at, it's a case-by-case situation, but primarily patient autonomy does triumph in that particular instance. And I think as practitioners, it's very important for us to start that conversation at that particular point, that one, every patient has the right to decide what they want to do with their own bodies to make these kind of decisions. However, should there be other reasons that now compel or basically would warrant that we take a different outcome, courts definitely are open to consider these applications so that they can look at the reasons that that the practitioner might not be privileged to at that particular time. But it's very important that one, act on the patient's in best interest, and also ensure that patient autonomy is upheld, but also still have an open ear to hear what the family has to say. It just makes it creates a more holistic approach to the situation.
Well, thank you so much, Reginald. I will pass the second question for now so that I move to a related one before we get to it. It's in the interest of Ivan. So in a case where assisted suicide is allowed by the court, is the treating doctor obliged to do it?
Hmm. Well, in that particular instance, well, that's a very tricky one. Remember also, as practitioners, we also have the right to be able to refuse treatment to patients. You know, you do have the right to terminate a doctor-patient relationship based on several factors that you might have, either perhaps maybe a hostile environment, or maybe you yourself find yourself having conflicting views because that's something that you also don't believe in. There is nothing that forces you to be the practitioner that actually carries out that particular act. You also have the right as a practitioner to also be able to uphold your own values, your own beliefs as a healthcare practitioner. Remember, the minute you step into the shoes of a healthcare practitioner, you don't lose your sense of self. You don't lose your rights and just become a robot, for the lack of a better word, and just are just ordered to do things. In that particular instance, I believe that the court, yes, will grant an order for say euthanasia, but they won't necessarily grant it and say it has to be performed by Dr. Masemola, for instance. You know, I think that the patient will approach whichever practitioner that they feel will be able to carry out that particular order by the court, and that practitioner, depending on their own position, their own belief, their own taking those things into consideration, may then take that into account. But yes, just in summary, no, you're not forced to do it. You also have rights as a healthcare practitioner. So you can terminate that relationship and say, I am not comfortable to carry this out. Please find yourself another practitioner, provided that patient care is still at the heart and that the patient is not abandoned for any reason.
Thank you, Reginald. That looks like a very much appreciated response.
I see that.
Yes. And then the last question, Reggie, is about a living will.
Sure.
It says, my understanding is that a living will is not a legal document. It carries no legal weight, but is rather an expression of wishes and directions. Am I right?
Well, a living will is actually a legal document. It is because it does provide as to what needs to happen to a person's estate. Yes, the position regarding living wills is a bit of a dicey one currently in terms of our legal framework. Um, but however, in the full essence of the word, it is a legal document. You know, because this is where you basically share your wishes as to what needs to happen, also to you, to your estate, you know, because remember, the minute we disregard it as a legal document, there's certain assets you have acquired and you would, for example, want them distributed in a particular way. We will use that living will in order to carry out. We'll look, of course, there are certain requirements that need to be met in order for a will to be recognized as valid. You know, it has there's certain formalities, if you can call it that, that needs to be adhered to. But once the formalities are adhered to and we're sitting ourselves with a very valid will, definitely it is regarded as a legal document and will be considered as such. Obviously, there are other exceptions to the rule, looking at, for example, the time period in terms as to when the will was actually executed and the time of death. The court does take those things into account. You know, for example, if you change your will today and 2 months down the line you die, obviously that just raises a few eyebrows, which the court will definitely look into account. And I think as family members or loved ones of the deceased, we can take that into account to maybe perhaps try and find out what were the reasons behind it, and the court will then, in that instance, make the necessary order.
Okay, thank you, Reginald. And I think this will be the last question. In terms of a living will, when a patient attempts suicide, how legal is a living will for DNAR for the patient side? I'm not sure if I read it well, but please check on your side before my laptop dies.
So in the case where assisted suicide is allowed by the court, is the treating the okay?
So it says in terms of a living will, when a patient attempted suicide, how legal is a living will for DNAR from the patient's side? Or
Do
do
not.
not attempt the patient?
Well, I mean, if I understand this question correctly, it's a bit vague. So it says that when a patient attempted suicide, so the patient tried to kill themselves, and now we're dealing with a living will that has a do not attempt to resuscitate. I mean, I think from that particular instance, the do not attempt to resuscitate document says do not attempt to resuscitate. That has to be upheld, you know, whether we're dealing with an issue of suicide that might, in that particular instance, bring maybe perhaps an issue of diminished capacity if there were such reasons that maybe perhaps a trained professional would then be able to comment on, because obviously that will then be taken into account. Maybe perhaps say there might have been other factors that maybe could have led to a particular patient wanting to commit suicide, which those factors perhaps could have diminished their capacity. And if then we have the view that we're dealing with a diminished capacity type of situation, that do not attempt to resuscitate order will then be looking at the timelines, looking at when this order was actually granted. Was the patient actually of sound mind and capacity at the time they were making the do not attempt to resuscitate order? And if the answer is yes, I don't believe that suicide would have necessarily a bearing or an effect into the order, because it will just be historical background information. But if we are of the view that when this order was granted, or the order was made by the patient, they were full capacity, they understood the legal consequences, and they understood the risks that came with it, I don't see any reason why that document will not necessarily uphold in court. But once again, because of that background of suicide, it could have, for example, some psychiatric issues, which could have affected that capacity to act. So yeah, it's not always one size fits all. It's always just great to have a holistic view, but I hope I was able to provide some guidance.
Thank you so much, Reggie. Thank you so much. This has been very insightful. And I'm sure between you and Dr. Venter, we are well equipped with all the legal and ethical aspects of end of life.
Thank you so much. I really appreciate the time, Kenny.
Yes, and then we move on to another ethics topic on the ethics of pandemics. We all went through COVID-19 and dealt with a lot of ethical issues in between. And so today, Dr. Vuyiswa Khumalo will take us through what we learned and now understand, and versus what we did as well, and knew before COVID-19. So Dr. Vuyiswa Khumalo is a medical doctor with a wealth of clinical experience. She got an MPCHB at the University of Cape Town, and then honed her skills in family and emergency medicine during her internship at Prince Mshweni in Durban and community service in Kimberley. Her passion for acute care led her to obtain a diploma in primary emergency care, which in turn took her to the high seas, literally, where as a ship physician, she practiced maritime medicine and quickly learned that treating patients in the middle of the ocean comes with a unique set of challenges, and motion sickness being the least of them. Dr. Khumalo then transitioned into clinical research at the South African Medical Research Council's HIV Prevention Unit, where she solves health problems at a scale. This also led her to a career in population health, as well as a fellowship in public health at the University and public health medicine at the University of Witwatersrand. She's currently an MED public health medicine candidate, where she's attached to the outbreak response unit at the National Institute of Communicable Diseases, NICD. Dr. Khumalo remains committed to bridging the gap between clinical medicine and large-scale health solutions, because prevention is better than cure, especially where there's an entire population at stake. Colleagues, Dr. Khumalo.
Hi, good afternoon, and thank you, Mhlengi. All right, so good afternoon once again. My name is Vuyiswa Khumalo, and I will be presenting on the ethical considerations during outbreaks as well as pandemics and their response. So, some diseases are more likely than others to cause outbreaks, especially if they're caused by novel pathogens. Factors like how easily they spread, rates of mutation, as well as lack of immunity plays a big role in this. So diseases like influenza, COVID-19, and Ebola are prime examples, often spreading very quickly due to how they're transmitted and other environmental factors. We know that global travel as well as urbanization increase the risk of disease transmission. So it makes certain pathogens much more likely to trigger widespread outbreaks. The impact of these outbreaks extends beyond health. So healthcare systems become overwhelmed, economies take a hit, and societies also face significant challenges, such as inequities in care and misinformation. Pandemics then present very unique ethical dilemmas, particularly for healthcare workers who need to balance professional duties as well as looking after their own safety. So ethical concerns include how you prioritize care when resources are limited, how medical treatments are allocated, and the enforcement of public health measures that may actually infringe on individual rights. Decisions that are made during pandemics are usually made on the evidence that is available right at that moment. So for this presentation, COVID-19 will serve as a case study of ethics in pandemics, and the lessons will apply broadly to all pandemics. I just wanted to also just define outbreaks. So we know with outbreaks, it's more of a localized event, often limited to a single community or area. Epidemics are then more widespread than that, but still not global. And then pandemics are when you have the global spread of the disease affecting multiple people over multiple countries and continents. So South Africa's response was guided by several key legal frameworks, each designed to balance public health priorities with individual rights. So starting with the National Health Act, this provides the foundation for public health interventions in the country, emphasizes the duty to promote well-being as well as preventing harm. It outlines the government's responsibility to protect public health while also ensuring that there is access to healthcare services. The Disaster Management Act is one that many people became familiar with during COVID because this enabled all the emergency actions to actually take place. So these included the lockdowns and restrictions of movement. And this was to prioritize the greatest good for the greatest number of people. With the Protection of Personal Information Act, this may introduce other ethical dilemmas in pandemics or outbreaks. So we need to balance the rights of privacy and confidentiality with public health needs. So while outbreak surveillance and contact tracing are critical for these infectious diseases, it has to be conducted in a way that ensures that the individual's rights aren't actually compromised. So looking at COVID-19, this served as a clear example of a highly transmissible disease that had rapid spread and high epidemic potential. It caused a lot of strain on healthcare systems and caused high mortality rates and overwhelmed the healthcare system. So this rapid spread of COVID-19 was driven by the factors mentioned before, so global travel, urbanization, and new variants that would emerge. So the pandemic actually had quite a profound impact on public health, pushing the response systems to their limits. Measures like lockdown and social distancing were implemented to try and slow down the transmission, but their effectiveness varied. Throughout this all happening, healthcare workers were then forced to navigate challenging ethical dilemmas, especially when they needed to make a decision between resource allocation, patient care, and their own safety. So when looking at public health and individual rights, we saw in the COVID-19 pandemic that lockdowns and vaccine mandates created quite clear ethical tensions. On one hand, the measures were necessary for public health and the public good, but on the other hand, they raised concerns about personal freedoms as well as autonomy. So in South Africa, the lockdowns were implemented to protect public health, but they limited people's freedom of movement. This led to debates about individual rights versus the collective good. And similarly, when vaccines started becoming available, vaccine mandates were instituted. And these also presented a tension between doing what's right for public health and also the individual's right to choose. And then when it comes to privacy, we've got the POPIA Act, so the Protection of Personal Information Act. So in South Africa, this has to be balanced against the need for effective outbreak surveillance as well as contact tracing, because that's what's needed to control the spread of these infectious diseases. So movements would be tracked, health statuses were also obtained, and a lot of this information was quite sensitive. So while protecting privacy is essential, the urgency of controlling the outbreak sometimes meant that public health measures included the mandatory reporting, which collected and shared this very sensitive and personal information, raised questions about how this data is actually shared, who has access to it, and how long after the pandemic ends should it be stored for. What also happens during pandemics is a no regrets strategy or policy. So this is how decisions are made at that time, because it ends up saving lives as well as livelihoods. So waiting for better data or evidence generally isn't an option within a pandemic setting. Decisions need to be made quite quickly. And with the COVID-19 pandemic, rich countries had the option of bucket loads of money which they could use to mitigate using this policy. Once they were able to do their research, they were able to update their policies quite quickly. But with developing countries, the resources just weren't there to do this. So when using this no regrets strategy or policy, we need to follow the highest priorities. So we need to be choosing interventions that are sensible under a wide range of scenarios, including the worst case. And no one knew how the pandemic would actually play out. So that strategy was used to suppress the virus to a manageable level as best as was possible. And so this tension between privacy and public health and the public good highlights the importance of ensuring that outbreak surveillance does need to happen, but it needs to happen in such a way that an individual's rights are actually safeguarded. All right, with the data collection and use, we saw with COVID-19 how timely, accurate data collection was quite essential for an effective public health response. So we had real-time surveillance systems. They tracked case numbers, we saw hospitalizations and deaths, and all this information allowed for targeted interventions to be implemented. The pandemic had created an unprecedented data collection on how people in the country moved, what their health statuses were, and what sort of health behaviors they had. This also raised concerns about consent, ownership of personal information, and the long-term usage of the information that was gathered. So while emergency data collection is justified during a crisis like a pandemic, there need to be clear frameworks for how the data is retained, ensuring that the data is anonymized, and how the data will be used after the pandemic. For example, in some cases, prolonged lockdown periods caused unintended harm. We know the economy suffered, there were quite a few mental health crises, and there were also delays in essential healthcare for other health or medical issues. But conversely, in other countries that reopened their borders quite early, this led to a resurgence of the outbreaks, putting further strain on the healthcare systems. So there are quite a few inconsistencies with all of these policies, and it highlights the challenge of balancing what's good for the entire population over what's actually good for the individual. We also don't have a standard framework for how research is conducted during a pandemic, so how operational research or outbreak-related research is conducted during a pandemic. The COVID-19 response actually showed the need for transparent, evidence-based policies that weigh both the benefits as well as potential harms. An example of this was demonstrated in the rapid reviews that used to be published on the National Department of Health's website. So these were rapid reviews that were conducted on studies on treatment options for managing COVID-19. So, for example, there was a vitamin C rapid review, there were corticosteroid rapid reviews, azithromycin, etc. So as soon as information became available, there was a team working on getting this information and disseminating it to all healthcare workers in the country. And these were continually updated as new evidence as new evidence became available. In terms of equitable access to healthcare service, the COVID-19 pandemic revealed the global inequities with the development of the vaccines and who actually had access. So high-income countries had secured advance purchase agreements of the vaccines, sometimes up to 5 times what their populations needed. And by the middle of 2021, a great majority of vaccines had gone to wealthier, well-resourced nations, while many low-income countries had vaccination coverage rates of less than 1%. So this also then raised the fundamental questions about global justice as well as fair allocation of life-saving resources. There was the COVAX initiative, which was designed to address this, but that also had its own challenges with implementation. And in South Africa, we did see a clear divide between urban and rural healthcare, also between private versus the public healthcare system. Inequalities became more pronounced during the pandemic. Resource constraints also led to difficult triage decisions in underserved communities, and how healthcare workers were distributed in the country also showed us a lack of equity to access the health services for people that needed it most. And when looking at how vaccines would be rolled out in the country, initial vaccine prioritization frameworks focused on healthcare workers as well as the elderly, so elderly populations. Some communities faced practical access barriers such as need for transport, needing to be registered on particular digital systems, as well as requiring specific documentation to get the vaccine. So this further exacerbated the inequitable access to vaccines in the country. When looking at resource allocation, there are many models globally that were used. So some looked at age-based models, so protecting the vulnerable, the very young, and the elderly, and others looked at occupation-based or work-based, so essential workers. And they all had different interpretations on what it meant to be fair or just. With South Africa, the approach looked at vulnerability, so the elderly, those with comorbidities or immune suppression, essential workers, and the risk of transmission. Other countries emphasized either protecting vulnerable populations, or economic recovery, and this all had quite varying results. There were also early PPE shortages, and this created difficult ethical dilemmas for frontline staff. The ability to test for COVID-19 was also quite a topic of discussion, as not all of the testing facilities had the resources ready to test. So the ethical principle of utility guided how testing materials were allocated to different areas, and they were chosen through highest transmission rates as well as vulnerability of the population. And then looking at the ethical use of quarantine and isolation. Quarantine is one of the oldest ways of stopping disease transmission, but we know it also restricts individual freedom. So restrictions, if they are implemented, need to remain proportionate to what the public health threat actually is, because we need to balance collective protection with minimizing individual harm. And this requires ongoing ethical assessment. So in terms of monitoring and evaluation, this needs to be a fundamental part of any pandemic response, as it supports ethical as well as effective decision-making. So when real-time data is collected and analyzed, it enables informed choices that prioritize public health to be made. Looking at how resources are allocated, we looked at fair distribution of resources such as medical supplies and hospital care, and this is essential to ensure that all communities are able to receive adequate support. Stakeholder inclusion in creating these interventions is also quite important. So in the case of COVID-19, important stakeholders would include frontline health workers, subject matter experts, and the populations that were affected, because this would help to refine the different response efforts to meet the real needs of the different groups that were affected. And as I mentioned, with the no regret strategy or policy, it adapts and evolves over time. So adjusting strategies based on new evidence allows us to prevent harm when the measures prove ineffective or there are unintended consequences. And so this process of evaluation of the pandemic response isn't only done once the pandemic ends, it's done continuously throughout the pandemic to help identify gaps, learn from challenges, and mount an appropriate response to the pandemic. To conclude, this presentation has highlighted the major ethical challenges faced in public health responses, especially during pandemics. Issues such as balancing personal freedoms with public health measures, ensuring fair resource distribution, and protecting privacy and confidentiality, while also ensuring adequate responses, are key concerns that require careful ethical consideration when these pandemics or outbreaks occur. A major takeaway is the need for clear ethical guidelines on how data is used, on how operational research is conducted during pandemic, and how interventions can be equitable. And without these frameworks in place, responses can become inconsistent, leading to ethical dilemmas as well as reduced public trust. And we also require the continuous evaluation of policies and interventions that are implemented so that we're able to respond effectively and appropriately to the evolving needs and the evolving evidence that's present during pandemics. And moving forward, strengthening public health systems through ethical planning is essential. Proactive measures such as transparent decision-making, accountability strategies, community engagement, and strategies for pandemic preparedness can help and ensure that ethical principles are upheld in future public health crises. Thank you so much. I also just wanted to let you know about the NICD hotline, as I am based in the Outbreak Response Unit, and the Outbreak Response Unit is the custodian of the hotline. It's a 24-hour dedicated support line for healthcare workers that need guidance on infectious diseases and public health threats. It's staffed by clinicians like myself in the Outbreak Response Unit, as well as some pathologists in the different NICD centers. So the hotline provides technical advice on a range of infectious conditions. So if you're suspecting an outbreak or need clinical or diagnostic guidance related to infectious diseases, please do reach out. Thank you so much.
Thank you so much, Dr. Khumalo. Very pleasant presentation with no questions. I suppose another indication of clarity, especially given the number of hands that I'm seeing, clapping hands and thumbs up and the hearts. So that was exciting. And I think it really took us back to a critical time when we were not sure whether would make it through the next wave or not as individuals. And also, I think for most of us here, I don't think we've ever worked so hard in the healthcare system as we did during COVID-19. And throughout that time, there were so many ethical issues that were not taken into account, which I'm glad you have raised. Some of them were out of sacrifice, and others are ignorance. So thank you so much for your presentation. We really appreciate it, and yeah, it was very informative and insightful. So colleagues, welcome. I will hand you over to Dr. Mbali Mngomezulu, who will take over from me. She's an amazing host and then a very productive member of SAMA. So over to you, Dr. Mngomezulu. And from me, it's good night.
Thank you, Mhlengi. As Mhlengi has mentioned, my name is Dr. Mbali Mngomezulu. I am a public health medicine registrar at Sefako Makgatho Health Sciences University, and I'm currently rotating as part of my training through SAMA. So I will be facilitating the second and last session for this webinar. And this session will tackle the ethical and practical implications of commuted overtime in the South African healthcare system. So our speakers for this session are Dr. Percy Mahlati and Dr. Luvuyo Bayeni from the National Department of Health. I will start with the bio of Dr. Mahlati. Dr. Mahlati is currently the Deputy Director for Hospital and Tertiary Health Services, Human Resources for Health, Nursing Services, and Health Infrastructure at the National Department of Health. He holds the following qualifications: an MBCHB from the University of KwaZulu-Natal, an Advanced Management Program from Manchester Business School, a Master in Philosophy in Values and Policy from Stellenbosch University, a PhD in Social Science from the University of Fort Hare. His major interests lie in policy development in various fields, including writing articles for public discourse. Dr. Mahlati is a published author, having published 3 books. He's played a major role in the development of various national HRH policies. He's also a fellow of the Africa Leadership Initiative of South Africa. He is the secretary of the Strategic Dialogue Group and is formerly the CEO of the South African Medical Association. Dr. Luvuyo Bayeni is currently serving as the Chief Director responsible for Human Resources for Health at the National Department of Health. He is a visionary force in South Africa's health landscape and a trailblazer in strategic public service transformation. With over a decade of leadership spanning from clinical management to executive roles, earning a reputation as Dr. Fix-It, following his track record of navigating complex challenges to create sustainable, people-centered solution. His contribution in healthcare has been recognized through the South African Medical Association Special Award. His leadership does not stop at healthcare. He has demonstrated his capabilities as a board member for the Eastern Cape Academy of Sports and Boxing South Africa, where he passionately advocated for the well-being and development of athletes across the country. The Eastern Cape Department of Sports awarded him the MSc Special Award, acknowledging his leadership and impact in football and boxing. He combines his board experiences with a medical and MBA degree to drive governance, change and crisis management, and policy alignment with proven results in operational efficiencies and public trust. He is a dynamic keynote speaker and influential communicator who also promotes edutainment through several radio slots. Yes, so those are our two speakers for this next session. Please remember to post any questions you may have in the Q&A chat box. Over to you, Drs. Mahlati and Bayeni.
Good evening, colleagues. Dr. Mbali, uzoniphelile ngomsebenzi. You can't throw us together at the same time with my boss. It's either you should decide if my boss speaks first, and then I'll just add and say I agree with my boss, or you say I speak first and my boss corrects whatever I would have said.
Apologies. Yes, Dr. Mahlati, may you please take over?
Dr. Mbali?
Yes, Sibo?
Dr. Mahlati is still attempting to log in.
All right. Thanks, Sibo.
I'll just ask him.
All right. While we wait for Dr. Mahlati, Dr. Bayeni, can you please take over? Thank you.
I hope that my presentation is also visible. And thank you very much for the introduction. You made me feel a bit not sure if you were talking about me for some time. Thank you very much to the organizers. And it's a pleasure to be here and to participate in this webinar. I think I've also learned a thing or two. Some of the issues I feel like I could go back to clinical practice and at least demonstrate what I would have learned from the webinar. I've been asked to focus on the issue of commuted overtime. And
Dr. Bayeni,
yes,
Dr. Bayeni, sorry for interrupting. If you don't mind, can you just full screen your presentation?
There you go. I hope I'm good.
Thank you.
All right, thank you very much. Sorry about that. I was asked to just comment on the commuted overtime issue and just share an update as to what have been happening in our space. And I'm happy that my boss will talk after me so that at least the wisdom can come from his angle to conclude the matter. I summarized the presentation, colleagues, as an update in terms of provincial consultations. Of course, in terms of the times that we find ourselves in, we are indicating or trying to emphasize that amongst other things that we are very much mindful of is the issue of emphasizing that there is a need, there is a need to focus on the workforce investment, and amongst other things on the investment is to remind and also emphasize that indeed our value add as human resources for health should be understood in the manner that without investing in the human resources for health, in actual fact, even the country's plan or economic growth could be affected, because if you don't have a healthy community or citizenship, you would not have any successful economic growth issues or plans for that matter. So that's what we're emphasizing under human resources for health in terms of being so emphatic as well as intentional to remind people that we should be forming part of the discussions that talk to workforce investments. But of course, amongst other issues that have been an issue that was at hand for us is that in terms of HRH policy, not only committed over time, but all policies that we have in the space of human resources for health have got a very long or an old timeline. The youngest, if I can use that term, would be a 2012 policy, but all of them are beyond that. And by virtue of timelines, it is necessary for them to be reviewed, let alone that to ask ourselves the relevance thereof in terms of now versus when they were initiated. But of course, we won't lie or hide it that we've also been having a pressure in terms of identifiable administrative inefficiencies that have been there, especially having been flagged as amongst the contributing factors, RWAPs and committed over time. But of course, we've had some pressure, if not feedback, from Auditor General, who constantly flags the high cost of committed over time, despite complaints about quality of care. Of course, in the health sector or health space, we are controlled or mandated to follow in terms of the highest decision-making body being that of a National Health Council, which is a ministerial committee that is involving all the main MECs as well as your heads of department. So in 2023, we were directed then to go and do reviews in terms of the policies that are there. But of course, also the other issue there was that departmental heads of departments were asked to take charge, if not rein in terms of the issues that relate to committed over time expenditures in their units or provinces. But of course, there was a special National Human Resource Committee that was convened as well to consider the work that has been prescribed from the NHC, and that's what we started engaging in. I can confirm, colleagues, that of course this work has also not been something that the department was handling on its own. We've had some media attention in terms of handling the work, but also interesting that indeed the issue of committed over time has been coming in for the past several years. As you may see that around the same time, if you compare the timeline of these articles, there was January and February a year apart, but still talking to the same thing of committed over time. Of course, we've also seen that even this year in January, different provinces were having a bite or issues that related to committed over time. But in terms of our space where we were directed as the administration, amongst other things that we have picked up in terms of issues that were related to committed over time, is the fact that in terms of the policy that was signed off and updated 2016 September by the minister then, who is now the minister, Dr. Aaron Motsoaledi, it still talks to medical doctors performing committed over time. And this we can raise that it's one of the things that comes up as an Auditor General's finding, that according to when they audit in the provincial space, you will find that there are provinces that would put up and pay dentists to do overtime, or maxillofacial specialists, which according to definition will then fall under the dental practitioners, not medical practitioners. So by virtue of audit, in terms of Auditor General's findings, that becomes an audit query because they are not covered by the policy. There was a solid current expenditure of about 7 billion on committed over time. and the discovery that it's been poorly managed at facility level. There are those doctors that were picked up to be contracting at high category, management administrative lapses at facility, but also there were individual doctors that were picked up to be claiming overtime for the work that they have not done. Others are in administration, others are not even still working in the facilities that are still paying them off. And others have been on leave, whether it be long leave, sick leave, special leave, but people will be claiming when they did not perform any overtime. But of course, we have also picked up and have been having reports that also confirm that in some facilities, there are managers that are conflicted as they also benefit from poorly managing commuted overtime. An example being that of a manager that would be on overtime but not doing any overtime work and getting salary. So it's not easy for them to manage and correct that practice if they are part of it. This is what we know and what was then instructed to provincial HODs during that NHC, that in terms of trying to have some accountability as a form of managing the commuted overtime, those who are in group 1 and group 2, then there was an instruction that approval should be set at facility manager, which is appointed at level 12. That will cover your districts, which will then be managing your CHCs. And then those that are doing group 3 should be approved by district managers and anyone who's appointed and having a responsibility of level 13 and above. This will cover your regional and tertiary hospitals and central, whose CEOs are above level 12. And then in group 4, the instruction was that anyone who is supposed to be put on group 4 should then be approved by provincial head of department or a delegated official, but it becomes a provincial competence. We had been borrowed this slide, colleagues, to just express what the Auditor General has been talking about in terms of the financial findings. It is a slide that has been borrowed from Eastern Cape that reflects how the expenditure patterns have been going on commuted over time. If you look at the financial year 23-24, it was sitting at 828,496 rands. This is millions, it's not thousands. We are talking about 848 million that has been spent on overtime in that particular year and province for that. So this is that if you have been raised very by both nationally as well as provincial treasury, where they are saying that there is money that is under COE in the Department of Health, and some of it is under commuted overtime. They would like to see efficiencies being improved in terms of managing that particular expenditure. We were then instructed to do provincial consultations. When we were visiting provinces, colleagues, we have visited 8 provinces. Only 1 province has not been visited for the consultation, and that province is the Eastern Cape province. We can confirm, though, colleagues, that you mustn't think we have left out Eastern Cape because I'm originally from Eastern Cape. We had scheduled sessions for Eastern Cape, but they were taken over by a sequence of events. And one of our visits was ended up being a working session in the Nelson Mandela district, where we were literally joining the department to do an exercise of checking each doctor that is in the Nelson Mandela district, which we did for 2 days in terms of where are they with their contracting and their commuted overtime. So there was efforts to come and visit the province. It's just that other issues would then come into play. In terms of our approach, our target audience was the clinical managers and the CEOs, HR managers, clinical services, district health services, social partners in the form of labor, as well as health faculties. But I can report, colleagues, that we were not able or successful in terms of having health faculties participate in those forums. So that has not been met, or that audience has not been reached. I can also share that the reason we included social partners or labor was, one, we were not coming to disturb whatever provincial relations that are there between your social partners and your provincial management. So we didn't want to give an impression that we are coming to discuss issues that relate to employees and leave a mess. But we were also trying to be transparent so that they understand that this is a consultation where we are busy trying to see how can we improve the policy, as well as giving them an opportunity to share their views and create an expanded platform for them. Under policy discussions that we were consulting on, mainly it was commuted overtime and RWAPs, but we were also giving an update on rural allowance, OSD, and community services. Well, when we prepared for these sessions and these visits, colleagues, we looked at the current policy, which is signed off September 2026. I am aware that most of the provinces or members of the medical space they report that they've got an access to a draft of 2016, not necessarily a signed off, but we do have a signed off, and I think we would have shared with Sama, of 2016, as signed by the Minister, Honorable Motsoaledi, at the time. But what we realized, which was an embarrassment, was that there was nothing fundamentally wrong with the policy and there were no changes much that we needed to do. However, when we looked and went through page by page, these are the changes that we were proposing. The first one, of course, is to talk to the issue of the definition or scope with respect to maxillofacial surgeon, as an example, maxillofacial surgeons eligibility, but also, of course, looking at the dental fraternity in its entirety. But what we also realized that the current policy has got in its form even some management and monitoring issues that are in the policy, and we felt that we could take those and compile what we refer to as a committed over time management and monitoring handbook, which we are hoping it's something that can be accessible even in an app form or in a click of a button for people to peruse and get used to. Then we had an issue that we felt needed to be looked at as to what is it that we want to be focusing on. Is it an emphasis on time worked or services rendered, or to look at a terminology that talks to on-site and off-site and determine how do we remunerate those. The other issue that we said should be also clearly defined is to make sure that there is a clear definition or interpretation of standby, which will be in alignment with committed overtime. You would recall that currently there is a standby interpretation that relates to labor relations or DPSA documents that talks to everyone who's working in the public sector. But we needed to ensure that in the new policy, there is a clear distinction or an alignment with the committed overtime policy. The issue that we wanted to raise very sharply as well is the issue of accountability, that the policy must also emphasize where is the accountability supposed to be held at, or where is it supposed to be focused at. And we're saying the accountability should cut across the board from your heads of clinical departments, clinical managers, and institutional heads through to provincial HOD in terms of being accountable for managing the committed overtime. And of course, the other issue is the issue of determination of need. The current policy colleagues have got a section that talks about the determination of need, where it even prescribes to say around September the preceding year, all facilities must then review their workload, review their performance, and identify or determine what is the need that is going to be there in terms of clinical space, in terms of patient load. That will determine how much of the committed overtime will be needed or how it will be distributed. So we wanted the policy to also be emphatic in this matter, summarize it if it's too long, or be clear if it's too vague or ambiguous. The other issue that we thought should be also included in the proposed changes is the issue what we refer to as categorization, where we are saying that there needs to be some guidance in terms of professional category, which categories are we considering for which maximum determinations, as well as the issue of facility needs categories, that there are facilities that we would know in terms of their status may not need to have a certain category of coverage because of understanding what the facility offers in terms of the service package. We can confirm, colleagues, that when we looked at the policy, we also realized that this issue or the policy review or the time we are in might not only be about committed overtime, it's about what we refer to as other emerging themes. Amongst those was obviously the first one that came to mind was in the current space, there is a lot of talk, a lot of efforts, and even intentions to look into the shift system. And we said, no, that could be a theme that we need to pay focus to and have an attention that we are giving. But also, we have picked up that there could be an issue about monitoring. What is available, what is there, what could work. So we also need to look into the monitoring systems. But the major issue for us was that, amongst other things, this is also a reflection on the capabilities and the capacity of the clinical governance, where we felt that there needs to be an attention that is given to clinical governance strengthening. And lastly, we said, maybe this is not the right question or the right issue to discuss. Maybe we should be, as a country, be looking at whether are we in the right employment package for doctors and clinical personnel or not. So that is what we were bringing forward when we were going to the provinces to say, amongst other things that we want to correct or change or improve on in the policy, but there is what we refer to as emerging themes that we're guiding people to say, we are open to say, let's discuss these things, let's have ideas, let's see how we can also respond, which we feel will also support and strengthen whatever changes are made into the committed overtime policy. Having visited the 8 provinces, colleagues, we just wanted to summarize what is it that we felt was coming up prominently in terms of the overtime consultations. We can confirm that there was a widespread acknowledgement of policy mismanagement or implementation thereof on the sessions we have attended. But also we can confirm that there was an obvious, sometimes demonstrable conflict in terms of clinical managers being defensive and non-committal to change, especially those that would have been affected. But also we appreciate that there is a young breed of clinical managers that is embracing to say, can we be part of the change as to how it's going to turn out? But we understand that every time, every policy has got a moment where it must be reviewed, and we would like to participate in that. The CEOs and the HR managers that had attended felt that the platform was ideal to clarify where does the policy stand and what are the issues that needs to be given attention. But we have also heard and picked up that there were areas where there was a deliberate manipulation and misinterpretation of the policy. But also we can acknowledge and confirm that there are provinces that had already done their own provincial policies to mitigate against other HE findings, an example being that of Western Cape and KZN, where we can confirm that in KZN, their provincial policy has got an inclusion of dental practitioners, which is why they would not be having a HE finding when it comes to how they pay maxillofacial and dental dentist category in other places. The other issue that came out very strongly in the findings was indeed the emphasis on clinical governance structures that have not been monitored and committed over time, and it has just been left to human resource management. And also we have had an observation that those that participated from the labor were actually very constructive, especially when it came towards the ideas and discussions around controls that deal with committed overtime management. When we came back from these consultations and finished and we had to present, we have also noted that in terms of where do we find ourselves now, we are of the opinion that when we scan the environment, it is acceptable to necessary reforms, but obviously bringing mixed feelings or reception, especially amongst the medical officers. But we can also confirm that there has been a bit of a challenge in terms of provinces not being able to implement the management changes in terms of what has been reported as inadequate or inefficiencies from their side. The unfortunate situation that we find ourselves in is that it still remains that the compensation of employment budget still remains inadequate to a point, and we have been directed that we need to improve efficiencies to see if there are no savings that we can pick up on committed overtime as an opportunity currently to improve on appointments. We have had a update to give to National Treasury, who had instructed us that we must go and see how we can then make efficiencies in the committed overtime. There is still a buy-in that we have started with the process, and they are comfortable that we are consulting provinces and would also be supporting if there are any identifiable trade-offs in terms of appointments. The minister that has come in terms of the new appointment, because by the time that we went for elections and a new minister was appointed, we had already started with the consultations. So there is a continued ministerial interest on policy review and change management. And we have also had an opportunity that we stand having an invitation to try and brief and update or even have a consultation with specialists and medical associations as an opportunity that is available to us. And maybe we can confirm and appreciate that Sama has already asked us to update on this matter. Shift and skills mix discussion is something that we are also having, even starting it from the support from the partners, WHO, amongst others. And we have also asked them to do a desktop exercise for us to identify and see where do we stand with the possibility of this discussion of the shift and skills mix discussion. In conclusion, I put a quote that is from Vex King, which says, "Step out of your comfort zone and face your fears. Growth takes place when you are challenged, not when you are comfortable." This is also true to me, colleagues. When I started the work of consulting in provinces, I had to get out of my comfort zone and also face the fears. But importantly, I can confirm that colleagues have been challenging me, others saying that now that I'm in administration and no longer getting overtime work and getting paid, I'm challenging the issue of overtime. But that's besides the point on my part. I believe that this is about us having to make an input and also having to be instrumental in how the changes in terms of healthcare system can be done. Unfortunately, colleagues, there comes a time when a few people have to be the ones to be bold enough to make a difference or to stand on what they believe in. And unfortunately, we find ourselves in that situation that we are the ones that ought to be discussing the issue of commuted overtime. We agree with the sentiments some of the people are saying, that the issue is not necessarily the overtime issue. It might be what we are being paid in terms of basic salary, which is a discussion that is different that we need to start tackling. But the reality is that commuted overtime in terms of its own policy measure or policy issue, it's supposed to be closing and covering when the work is done outside working hours. And we are standing firm to say, when people are convincingly doing their work, we don't stand in front of that. But when people are not doing their work, or there is no need for them to be seen to be doing work, then we feel that it's about time that we all become part of those who are going to improve efficiencies when it comes to managing the healthcare system. Thank you very much, colleagues. That's where I would end for today.
Thank you, Dr. Bayeni, for your insightful presentation. Your contribution has, deepened our understanding of commuted overtime. There are currently no questions in the Q&A chat box. So I take it that, it's because you had a very clear presentation. Dr. Mahlati, thank you for joining us today. Your attendance is greatly appreciated. I will now hand over to you, Dr. Mahlati, for any further insights.
Thank you very much, and thank you to Dr. Bayeni for covering a lot regarding what we've been invited to share. I'm just going to share a few slides just as a backup to and demonstrate some of the challenges that we've been facing that Dr. Bayeni would have covered. I'm hoping that my presentation will be, let me then put it on slideshow. I hope that you can be able to see it. Yeah, I thought I should, start with a few basic principles because we've actually picked up that quite a number of colleagues, especially young colleagues, have got, I would say, a different understanding of what the term overtime means. The first really is to say overtime is a service demand-led activity. And overtime is done across many professions. We're not the only ones. But we're peculiar in medicine because there was a special arrangement that was made to say that because doctors fairly get overwhelmed with their work, it would not be possible for them to all the time be, filling in, hours or how many patients they've seen and all that. So I think colleagues then, policymakers, coined the term commuted overtime so that it could be distinct. There is no other profession that does commuted overtime. It's the medical profession. Like Dr. Bayeni has indicated, management of overtime can only be done at facility level. It is not automatic for every employee, and overtime for juniors is necessary for exposure to the complex challenges that we have in our health system. I'm raising this point because one province called me saying that junior doctors were saying that it is compulsory in terms of HPCSA for them to do commuted overtime. Then I corrected that and said, look, clearly it's important for them to be able to learn to work at any time of the day with any load that is there. But if there is no demand for overtime, why would you then, say that people must? So the facilities must do proper rostering and make sure that the juniors are also exposed to the challenges. And make sure also that they've got adequate and appropriate cover so that we do not have a situation where juniors are actually left alone to work through the night. There's a bus accident. They don't even know, how to manage things. So we thought that maybe one of the things, because they were saying that they're actually earning, or one of them said to me they're earning slave salaries. Then I was actually surprised, because if you were to compare with comparable professions, engineering, law, accounting, and so on, I'm not sure if there is any who, when they actually do their first year after qualifying from university, are able to command the salaries that we're showing here. We decided to do a comparison from 2022-23 financial year right up to 24-25 where we are. And as you can see, for a medical intern year one, starting at 524 to 80, right up 3 years ago, right up to 587, 680. Year two, community service and medical officer, and you can actually see the jump in terms of the medical officer, close to about 200,000, between finishing community service and, starting as a medical officer. So we pulled this table to also, because this is without commuted overtime. Now, if we get to commuted overtime, we've pulled the same grade one, the one that would be doing 12 hours and those that would be doing 16 hours. For those that would be doing, 12 hours, on average, it would come to about 31,552 per month. So if you were to actually multiply that by 12 and add to that salary of 949,146, somebody potentially ends up earning 1.3 million per annum. Of course, you'll tell me that the taxman comes, SARS comes for every one of us. For the one who's doing 16 hours, that actually pushes it up to 1.453. So that would be on average. Of course, not everybody does the same, hours. So it should not be misconstrued that one is saying everybody is doing this. But the Auditor General in the Eastern Cape, I'll mention that, actually they sampled across, and they actually find quite a number of anomalies. I will not go into detail, but some of those was that, for instance, in one district, every medical officer was contracted at 16 hours, none below 16 hours, despite the fact that in some of the facilities, there will be no activity at all at night. Some of the colleagues, they had approved their own overtime, which is illegal. Some of the colleagues had actually earned, commuted overtime pay without seeing a single patient in a whole year. These are the issues that then we've said the problem is management at local level. And colleagues, part of that management at local is our own colleagues, medical doctors, who actually allow this abuse of public, if colleagues were actually seeing patients and are able to prove that, they've seen patients and, nobody would actually argue around that. So we are in no way painting the profession with the same brush, not at all. Just like in RWAPs, there are colleagues very senior who start at work at 7, 9 o'clock, they're out, they run their practices, but expect to be paid for the whole day. So these are some of the issues that we thought, let's pull up this, example so that, we can actually be factual. These are the figures that we pull out there. That is why then you get National Treasury saying, why do you want more budgets when you've got so much money that you are wasting? And they'll talk about RWAPs, commuted overtime that is not managed. And of course, we've dug in our heels around rural allowance, even though there are noises around it, because our view is to say you cannot collapse rural hospitals by taking a small incentive that keeps, our colleagues in there. But some of the things, it becomes so difficult to argue when those who are dishing the pairs are actually saying, but you are making, your system is leaking. And in some instances, they actually mention names in private. They say, no, you actually go to that town, you'll actually see even the plate on the wall says consulting hours 8 to 5 or 6. Meanwhile, that 8 hours they are supposed to be actually working. So this is a serious problem that actually makes it so difficult for us to be able to argue. And of course, we do put up a very stiff argument that actually says, don't paint the profession with the same brush. Now, colleagues, part of what is, here, he has covered it, with Dr. Bain. I just want to come to bullet point that talks about importance of clinical governance and the role, central role of senior clinical leadership. We waste a lot of money, we lose a lot of money to litigation. We lose a lot of money to litigation, and in many instances, you find that the mistakes happened when juniors were alone. Seniors were nowhere to be seen. In some instances, lawyers trick and they steal files. By the time, they actually apply for information, you must know they already have the file with them. They've bought somebody somewhere to steal it. So there is also a problem of corruption in the system, where people are actually, taking those and go. Some of the, cases that we face are cases that actually have got nothing to do with the quality of care of our practitioners. Is actually more patient, if I were to use that word, where people will book into the clinic very late. There are already complications and all that. So senior clinical leadership, colleagues, is very, very important. Now, this came from DBSA, where they were actually looking at, the challenges around remuneration. You'll actually see point number 6, remunerative work outside versus leaving patients in public service unattended. And they've actually raised the high remuneration in OSDs versus taking, SMS role. Part of this problem is because we would like really to have medical colleagues being CEOs of hospitals. But of course, people then say that if I go into that role, I'll earn less because I won't be able to earn commuted overtime. That's a serious challenge that we have. Some colleagues have actually, pointed fingers at me because I made a statement that doctors in public service are fairly well paid. Interestingly, a year ago, Begisisa Center for Health Journalism made a comparison within the African continent with what doctors earn in Kenya and in Nigeria. And if colleagues were to get to that side, you'll actually see that our doctors earn more than double of what the others are earning. I know that our propensity is to compare with Europe, Australia, and all that, but our economic standing is not actually at that level. So what I'm actually trying to raise here, this one I think Uluvuyo has raised. So in conclusion, what we are saying is that there is an absolute need to rein in costs associated with commuted overtime first. When it comes to RWAPs, there are colleagues that got RWAPs properly the way that it should be done. There are others who don't even apply. And unfortunately, we are informed that it has actually cascaded down to juniors, that they'll just leave work because they know the senior is not there. They go and do locums around, others start having their own practices and all that. Of course, we don't want to do what one HOD did in one province, where he went to BHF and pulled out that was before, this protection of information, pulled out, what the guys were making in a year and then confronted them. Say, well, you make so much and your claims were, were on this day, what, and all that. We actually don't want to do that. We would rather have the profession police itself. We would rather have the seniors guide the juniors properly, because we want to avoid at all costs applying a blanket approach and say everybody is doing the same thing. They are not. But if it's only done from management side and the profession is sitting back, we're going to have problems. Like I said, strengthen clinical governance. Clinician leadership must be accountable. Facility management, of course, improve. And I just want to end by saying challenges being experienced require grounded leadership on both sides. Perpetual fighting and shouting at each other is not going to solve any problem. I think the last quote that, Dr. Bayeni, closed with is basically what, this means. We all have to get out of our comfort zone. And if we do not manage the affairs of our own profession, nature does not allow a vacuum. Somebody else is actually going to come in and they will be very stringent. It has already started. So a genuine partnership is needed, but that partnership must have room for differences, because what is important is not the presence of differences, but more how we resolve those differences. The health system, universal health care, that would be funded through the National Health Insurance, is going to require that facilities be accredited. I know that is still a long way to go and all that, but let's say it actually started tomorrow. Where would we be as a profession when we've allowed some negative aspects of culture to consume us? The only thing that we engage on really is around salaries and employment. Nothing beyond that. Nothing beyond that. On policy issues and all that, which I would say colleagues need to remind you, colleagues, go back to the policy documents of a summer, 1998, 99, and so on. Very, very firm about what the role of the profession would be. Making sure that we don't allow space for political, mechanisms to control, Of course, there must be. And we used to make an example that we actually admired, the Norwegian Medical Association. The guys would fight with their minister, and in the evening, they would be in a cocktail having settled their differences. We've got a long way to go, but let's use the opportunities to do so. Once again, thank you very much, colleagues, for affording us, this opportunity to share this with you. We know that some people may not necessarily be very happy, but we're ready to engage. If there are differences, let's work through those differences. After all, this is our profession. We actually have to make sure that our profession does not go into the doldrums simply because we've differed on small issues here and there. Thank you very much, and over to you, Chair.
Thank you. Thank you very much, Dr. Mahlati. That was a very comprehensive presentation, and we appreciate your insights. We have some comments in the chat box. It's more of a statement than a question from Visva Naidu. If we know whether irregularities exist, why are they not being addressed? Those that are being honest with commuted overtime and indeed doing more than required are tired of being painted with the same brush. There's another comment from Dela Maywald that says, I think all doctors doing overtime that are chronically sleep deprived would happily give up overtime and work a 40-hour week. There is no point in junior exposure if the seniors, and let's be honest, consultant specialists sit at home and are not available to come and help with caring for the patients, while getting a fat income with a bit of RWAPs on the side during working hours. So just to add on, to this, or rather, let me pose a question based on these comments. So for a junior doctor who perhaps is constantly finding themselves, doing calls unsupervised or without adequate supervision from their seniors, what steps can they practically take, in order to get assistance in this regard, keeping in mind that, junior doctors need to be signed off. So, and they need to be signed off by these very same seniors. So, a lot of the time they might find themselves afraid to take this further, but are there any practical steps that you might suggest that a doctor could take, a junior doctor could take?
Yeah, let me start with that last one because it's a very, very important, question. I know that many of us get intimidated, by seniors. There was a time where, as public servants, you would never dare open your mouth because a senior politician or whatever, they would actually come like a ton of bricks over your head. Those times have gone. I think we've got to make sure that we stand up, And my practical, a suggestion would be that we cannot afford to compromise the mental health of our junior doctors. And there's quite several of them that have fallen into that fate who actually, sit back and not complain because they actually want that signature at the end of the day. Report to the HOD, district manager or HOD. You don't get any joy. Report to the National Department of Health. Dr. Bayeni here, unfortunately, is young enough to understand the language, where that would be coded, The other one is to report to the HPCSA. I can tell you no doctor wants to lose their license to practice because of carelessness. The colleagues have gone on with this thing because, like we said, there's been poor management at facility level. That is why, if you look at what Dr. Bayeni presented, we've actually said HODs take responsibility. You cannot abrogate on that and actually give to somebody. When there are challenges, then you complain. A very good example is that one province was complaining that they do not actually have their short staff, they do not have money to employ doctors. Meanwhile, their COT budget is R1 billion. Now the provincial treasury says, no, you will trim on that billion rands and employ more people, therefore less overtime that would need to be done. Practical things like those, but I think it's a very important, question that you are raising. And it would be good if, especially our juniors would actually act as a collective. Act as a collective, care for each other, and please report wrongdoing, because if I keep quiet and I see wrong being done and the next one keeps quiet, it actually becomes a negative organizational culture that takes root. Senior cover, yes, I think one of the things that we're emphasizing to department, to provinces, let's make sure that those who've got RWAPs, those, contracts get reviewed and they get, contracted for every month, every year, just like, the policy is. Why not address irregularities? I think we've been upfront and actually agreed that we do not want to paint every doctor with one brush. I've emphasized that several times. We don't want to do that, and it must not be done. The problem of weaknesses, for instance, some of the, I think there was a slide where Dr. Baini talked about, hospitals that are going on without, CEOs for a long time. Others is just the CEO and the supporting layer is actually not there. Therefore, you cannot expect that, the CEO would be an HR manager, finance manager, supply chain manager, and all that. These are some of the weaknesses, system weaknesses that we have. And basically, the view that we've taken, have been pushing, is to say, start with your central hospitals. We've actually gone on for quite some time with 10 central hospitals, only 4 having permanently full-time employed, CEOs. Now 5 are full-time employed. 5 of them, of course, there was a political challenge around that, where some people would actually want to employ people as CEOs of central hospitals who've got no clue about running a central hospital. Remember, central hospitals are also what you call university hospitals. That is where we train and educate our professionals. So you can't get somebody who was running a district hospital yesterday, tomorrow is actually running a central hospital. There are those teething challenges that we have. There is a clear policy, implementation is a bit of a problem. So all I'm trying to say is that we were pushing for managers to be given delegations so that they can effect discipline. Very important. But it would assist a lot, colleagues, if our senior clinicians would actually assist. If I'm running a surgical department or a gynae ward, and I actually find that, my consultants are not in, they come in at 10 o'clock, I should take them up on those, including to a stage where they might actually forfeit part of their salary, because it's only then that people would be able to learn. So we would really appreciate if, especially summer, because I know that it's got many specialist society, if it could actually assist in this, because this is really about the profession more than anything else. Because if the profession comes together and says, this is not acceptable in our profession, we get everybody in line, we'll be able to resolve all the others. We'll be able to show that the profession has actually taken charge, and therefore you cannot punish the profession by underfunding it when it is actually taking its responsibility. I'm hoping that I've covered those. Dr. Bayene, I'm not sure whether you've got anything to say. I was just sweeping the floor for you.
Thank you very much. If you allow, Dr. Mbali, just for me to add one and then probably respond to the fourth question on QA. I think, colleagues, one of the reasons that we probably were very excited with this invite, it's precisely because we are consistent in saying we can't do anything alone. And some of these issues needs the association and the profession at large to stand up and represent what they want to see happening in the health system. Furthermore, when we were linked to a topic on ethics, I said, it's exciting for me because when we were doing rounds and doing provincial consultation, some of the questions that we were getting and interactions we were getting makes us wonder as to whether is the profession still pursuing the right ethical path and as well as the professional path. I mean, colleagues, it is just a disgrace to the profession when I would stand up and say, I demand to be paid overtime. I know that I am working in the offices at James Exum or at Dukumbana building or whatever provincial offices that we work at. I've never been close to any hospital for the last 5 years or the last year, but I stand up and I say, you can't be taking away commuted overtime from doctors. You are undermining us and you are disturbing our salary and our income. So the question remains with us, and it's most relevant for the topic, where are our ethics? Where is our professionalism? And we are maintaining as a department, colleagues, when people are doing the work that they're supposed to do at the time they're supposed to be doing, we are obliged to make sure we remunerate them. So that's what we're asking, that we can work together as a collective and as an association. Like Dr. Mahlati was saying, the seniors and that are not there, it's our members, it's our colleagues. We need to start changing and making sure that we are the ones who stand for change. Yes, it might not seem as if we were ready for it. Others might argue that we are young for it, but unfortunately, the time calls for us to be the ones who stand up to protect even the very same integrity and profession. The question number 4 is the same issue I'm talking about, ethics. It's asking if are we allowed to sell calls even despite the colleagues. We said if we can strengthen clinical governance, half of our battles will be won, including the other issues that are stressing us of medical legal. Because clinical governance will be the one to try and make sure that seniors are available when people need to be the skills transfer. But secondly, clinical governance strengthening also involved how we manage the call roster. Obviously, we know that when we are rostered, we don't always preempt what's going to happen. But the clinical governance should be able to have systems of saying, I just discovered that I've got a commitment. I was supposed to be on call today. I've spoken to Dr. Mbali, who is on call on Thursday. We are going to swap the call and she's going to cover for me today and I'm going to be on call on Thursday. That's what clinical governance is saying. But we're not going to have a situation where I am on call and I knew that I'm not going to make these calls. I'm not available. And then I go around to say, can I sell my call to you? And the next thing, when you end up doing 6 calls because you were buying my calls, you come at the end of the month and say you were overworked. Whereas your calls that were allocated to you were 4, you bought the other 2 from me. Worse off, where ethics and professionalism comes in. When I sell you the call, I decide the rate, which is not what the state is paying me. So I still make a profit. Now I'm running a business that the state will pay me 3 rands. I come to you and say, I do my call for 150 and I pocket the 150. Where are we ethically? Where are we professional? So this all talks to what we raised as a theme and a concern for us, which is clinical governance strengthening. And that's how we need to be working together as a collective. Like I said, obviously the question is asking about circumstances. We cannot prescribe here and say people cannot swap, people cannot be available, because obviously we don't know what tomorrow holds. But the responsibility from our side, the professionalism, as well as the strengthening of clinical governance is what should make sure that our profession is protected, the integrity is not compromised, and there are no risks that will come back and haunt us. Thanks.
All right, thank you, Dr. Mahlati and Dr. Bayeni for those very in-depth answers. For the first question, thank you for sharing some practical sides, so practical steps that a doctor can take if they're not being adequately supervised during their calls. We forget, there is the HPCSA, and we can use like an avenue like that to lodge a complaint. And, that complaint can be anonymous. And yes, thank you, Dr. Bayeni, for touching on the issue of selling of calls. So in short, we can swap calls rather than sell calls. Yes, and I see that other questions in the chat box have been answered. Dr. Mahlati has just typed answers for those questions. We have another comment from Zabeth. They say that I'm a GP in Durbanville, and when I refer a patient to Carl Bremer Hospital as an emergency, they wait up to 48 hours sitting in a chair. Have been in this profession for 37 years and see my patients dying. Wow. So yeah, thank you for highlighting some of the frustrations that doctors face, when they're trying to refer patients and trying to get them the help that they need, that there are these challenges that you're facing as GPs. Let me just look at the chat for any further questions.
Maybe, Mbali, you can take my comment at this point.
Yes.
This is the CEO.
Yes, I would like to hand over to SAMA's CEO, Dr. Mzo Notegita.
Yeah. No, thanks, Mbali, so much for this part of the session. And I think we need to also thank Dr. Mahlati, the former CEO of SAMA, and our member there, Dr. Luvuyo Bayeni. For me, I think there's a number of issues that are involved here. One of which is that maybe it's not of our own making, but the processes that they follow, in the main, they exclude the profession. So I was glad to hear that there is an attempt to actually engage some and the other societies, because you can, well, you can, I guess you can, in terms of the framework, talk to the doctors who are working there and maybe assume or maybe have comfort that when you talk about labor or social partners, doctors, especially the professional aspect, will be represented. But I know that Dr. Mahlati knows better than that. And so that's why you would get some of the things that you get. But I think there is a conversation to be had around the salaries of doctors. And I think the comparison that Dr. Mahlati is making might be borderline unfair if you then compare how much time these professionals that is comparing the doctors with spend within their own training, and also just the type of work that's being done is worlds apart. So I think I am happy that we've got leaders within the health department who are aligned and want the profession to participate. We have on several occasions been saying that a platform probably needs to be created for the profession to engage directly with the Department of Health on issues that relate to the health system itself. The issues that Dr. Mahlati and Dr. Bayeni are raising fundamentally relate to leadership and governance. If the leadership and governance part of the building block of a health system is being ignored, I mean, the example that Dr. Mahlati made of central hospitals, which are the apex hospitals in the country, running without CEOs and proper leadership, that on its own is a problem. Because most hospitals refer as the last resort to these hospitals. And if there's no leadership and governance there, you've got a serious problem. So in essence, I think for me, what makes me happy today is one, the fact that in his capacity as the DDG for hospitals, so Mahlati and Dr. Bayen as chief director are willing to engage with the profession, because I can assure you that we're outside of those discussions in your visits to the professions. In some provinces, when we say, but we are a major stakeholder, some of our doctors in the main are some are members. They say, but you are not allowed in the bargaining chamber to sit there. So these are things that I think if we create that platform to engage, compare notes, because we will be able to share with Dr. Mahlati our own study that we have done within the salaries, and also just accept that the context, the comparison might be slightly unfair. But also, I mean, we know about the Pegasus study, and even there, the context of the countries and where those countries are is slightly different. So in a very calm and a professional manner, I think we need to have that session so that we can draft the way forward. I think there is a discussion to be had on the salaries of doctors and maybe manage a certain percentage of what is overtime, which false balloons what doctors earn, because it's not even pensionable. but it's counted as part of what the doctor can afford, and when they need it the most at retirement, even when women fall pregnant, they actually don't have that. So I think we do need the conversation with the department, and I'm happy that it's that part is opened. So thank you very much, Mbali. I thought I should just highlight those things. And just to also reassure Dr. Mahlati that in relation to RWAPs, that again is something that the profession, if it is not involved in the discussions, you won't be able to get our views. But there are internal controls and frameworks that at the level of clinical governance can be put in place to make sure that, because it's not a once-off signing of RWAP's contract. It's something that you can renew every year. And if someone is violating the contract, then you have every ground not to approve the next year. So these are control measures that the department itself, with its own leaders at the level of the facility or province, can put in place and make sure that if you violate, there are certain guidelines there. If you violate them, then you don't even bother us by applying for the next year, because you violated the RWAP's policy. So yeah, I'll stop there, Mbali, and yeah, thank everyone for being here. I see Dr. Mahlati's had immediately gone out.
Yes. Just one small issue, I wanted to raise. Thanks for your comments, and we're ready to engage on those. But maybe as CEO, I would like you to look at this. When Dr. Bayen and team were doing their rounds across the provinces, some of those clinical managers are your members of SAMA. So if they don't filter the information back to you, there's something drastically wrong. If they see their role there only as personal and not actually extending to the profession, there is a problem. So I really would like you to actually dig into that. I won't say who they are, but you should be able to find out, because it's important for them to feed back to the professional association. The second one around representation. Mhlekas, nobody's going to come and knock at your door and say, come here. We've got to find a mechanism of how we actually make the profession indispensable. Not in a manner that they would be seen in the streets or whatever it is, but let's sit down and actually engage on those, because that is very important. I think the last one around salaries and all that, yeah, we'll discuss. We'll take you back to the history of the OSD, how it came about, why we're making these statements now, the fiscus and all those things. But we will actually accept that. Uluvuyo, of course, will engage. Then we can be able to sit down and engage on those. But the main one I wanted to raise really is that members of SAMA must know that even if they're working in a hospital, they represent the profession. Therefore, that feedback loophole must actually be there. Thank you very much.
No, thanks, Doc. I think we will reach out to you for that, those engagement. I think it's important that we do. Yeah. Okay, Mbali, over to you. Thank you.
Thank you. Thank you, Drs. Mahlati and Dr. Nodigida. Dr. Nodigida, you touched on leadership and governance, and leadership and governance in our healthcare system does play a crucial role in shaping the delivery and quality of healthcare services. We have a comment in the chat box. Doctors are not trained in medical school around what it means to be an employee. Therefore, junior doctors sometimes struggle with HR processes and what they can do. More education on what it means to be an employee and HR processes is definitely needed as doctors progress through the ranks. And yes, I agree with that comment. Yeah, we're not really trained as medical students around HR processes, so that can be implemented into the medical school curriculum. We have another question, but it is around palliative care. So we can forward that question to Dr. Fender, and she can answer that for us, and then we'll share that question with our attendees. I see a hands up from Dr. Bayeni.
Thank you very much, Dr. Mbali. I think I was reading with you on the chat, so I saw that there were two questions that were there. One is in relation to capacitation in terms of HR processes and understanding those. There is two things that we can do, actually three. One, as summer, we can do these virtual platforms to try and capacitate our junior doctors in terms of that space. Not only junior doctors, the clinical managers as well, that are our members, so that when we receive any new employee, it doesn't have to be a junior doctor, but any new medical employee, we then take them through the HRH processes. The second one is if we want to probably assist, we could consider our ICSP platform, where all the junior interns and ComServes belong up until they qualify as ComServe, where then we can just try and see if we need to add a thing or two in that platform. But the third one is exactly what we started with, the strengthening of clinical governance. Because when you've got a stronger clinical governance, amongst the things that the clinical manager's responsibility is to ensure that all the clinical staff is treated equally like any other employee, including exposing them to trainings, including exposing them to all the regulations, including having a file when they start at work. So when we talk of clinical governance strengthening, that's also what we refer to. Our clinical managers need to be capacitated and understand that it's not only the clinical space that they need to play a role, but also the administrative space as well. The second question that I probably thought I would comment on, it's asking if we've got plans to expand, include, or accommodate, or even introduce the palliative care specialty. The direct answer is that we are fortunately reviewing the HRH strategy, which was released and signed off in 2020 for 2030. So in the review, amongst other things we want to take cognizance is where are we now with the health system? Is what is on the HRH strategy still applicable in the manner in which it ought to be? And what changes can we do? The second intervention that we can confirm here with you guys is that in the 5-year strategy that started with this new government, from HRH perspective, we have included an indicator that talks to the framework of multidisciplinary teams for district hospitals, especially medium to large hospitals. Our processes that are going to ensue will be to involve everyone to see how can we all define what is the framework of multidisciplinary. Our intention is to start making a voice for the new professions that we feel can play a space especially those that we know will work towards strengthening district health services as a start. That includes the team being led by a family physician, that includes the district having public health specialists, and also that includes how and what role do we have for the mid-level workers, including clinical associates. So I would like to maybe entice and invite that when we start that process, even if we might not have come through summer, when we visit on the ground, when we're doing that work, those of us who are available, but also we are more than welcome to inputs that could be even in writing. As I've shared now, we want to establish a framework that deals with the multidisciplinary system, a team. So we would still invite even a submission from SAMA to say, in their thinking, how would they want the framework to look like, what parameters or what professions should be part of that framework. The idea behind it is that come the end of the term in 5 years' time, we would then have to evaluate how many of our district hospitals have started to implement it. Currently, our target is to have 179 hospitals having implemented that framework by the end of the 5 years. So that's an opportunity that we are offering and availing and equally updating in terms of how can we work together as partners in ensuring that there is a change in the healthcare system in terms of how we do certain things. Thank you.
Thank you. Thank you so much, Dr. Bayeni. We have another question in our Q&A box, but it's regards to the virtual care and ethics that was also on the schedule for today. So that session has been cancelled. We apologize for any inconveniences caused, and we will look into incorporating that topic into another webinar. All right, it looks like there are no other questions. Yes, so there are no other sessions. Thank you to Dr. Mahlati and Dr. Bayeni for your time and your expertise and your very thought-provoking insights. We appreciate your time and coming to join us at our webinar today. And as we come to the end of getting away from Dr. Mahlati, thank you. Yes, so just as we come to the end of our today's ethics webinar, I just want to take the time to thank all of our speakers, for their contributions. Your contributions have deepened our understanding of, ethical decision-making in healthcare. Ethical dilemmas are really simple, but through, open dialogue and communication and continuous learning, we, can navigate these challenges. And we just would like to encourage you to take what you've learned today and apply it in your respective fields. And a recording of today's session will be made available at the South African Medical Association's YouTube page. And yes, once again, thank you. A big thank you to all our speakers and our organizing team, all the people behind the scenes, and all of you who've joined us today. We hope you have learned something, and yes, I hope you have a great evening further. Thank you for joining us.